This presentation is about pain. According to the International Association for the Study of Pain, pain is defined as the unpleasant sensory and emotional experience associated with the actual or the potential tissue damage, or described in terms of such tissue damage. Margot McCaffrey, who is an RN, she says that pain is whatever the person experiencing the pain says it is, and it is whatever it does. Pain is a protective and complex phenomenon. It's made of sensory experiences, and this can vary in terms of time, space, and intensity. And also, it has to do with emotion, cognition, and also motivation, as well as environmental factors. And first, talking about the neuroanatomy of pain, we realize that the portions of the nervous system responsible for the sensation and the perception of pain can be divided into three areas: the afferent pathway, the interpretive centers in the brainstem, which are the midbrain, diencephalon, and the cerebral cortex. And then lastly, the descending pathway, which is going through the brain to the dorsal horn to the spinal cord. At the level of the afferent pathway, or the PNS, we have the peripheral nervous system, which sends a signal to the gate, which is in the dorsal horn of the spinal cord. Once we get there, the signal will then move and ascend to the higher centers in the central nervous system. Once it moves from that pathway, it's going into the interpretive center. The interpretive center is within the brainstem itself. This is the midbrain, the diencephalon, and the cerebral cortex. Now it's interpreting what that pain sensation is, and it can also now send a message of where the pain sensation is coming from. Lastly, the afferent pathway is the descension of this message to the interpretive center, going to the gate again in the dorsal horn, back through the spinal cord, where there it modulates the pain. First, we're going to talk about the primary, and then the secondary, and then the third order neurons. Primary order neurons are nociceptors, which are pain receptors. They're detecting whatever the stimulation has been. It could be from a severe mechanical deformation, or it could be from temperature extremes, whether high or low. Think heat and fire. Then it's going to send this transmission in one of these types of fibers. In the myelinated A delta fiber, we have a very fast transmission, and it causes reflex withdrawal of the affected body part. So if you're touching something very hot, without even thinking about it, you're going to move your hand away. Okay, so before the stimulus even goes into the brain to be perceived. If you have pain that's moving through the unmyelinated C fibers, this could be stimulated by mechanical, thermal, chemical pain. It's very slow. It's dull, it's aching, or burning sensation with the C fibers. It's very diffuse. With A beta fibers, not to be confused with A delta fibers, these are also myelinated. They're larger, and they transmit touch and vibratory sense. Once we move through those fibers, we get to the secondary order neurons. These are interneurons that are located in the dorsal horn and within the spinal cord. There are three classes: projection cells, excitatory interneurons, and inhibitory interneurons. The second order neurons are located within the spinal cord laminae, and they function as the pain gate. This is going to help regulate that pain transmission. These neurons cross over the spinal cord, and they ascend primarily to the lateral spinal thalamic tract, projecting towards the center, including the thalamus, reticular formation, and the third order neurons. Now they're going to carry this information to the sensory cortex, the reticular and the limbic systems, and this is where pain processing and the interpretation of pain occurs. This term nociception, harmful or noxious stimuli through a normally functioning nervous system. Our body, our brain is trying to figure what is going on. Nociception. It happens in 4 phases, and it begins with the tissue wherever the damage is located or being affected by this noxious stimuli. Now it's being converted to an electrophysiological impulse or nerve impulse, and now moving through transmission. In transmission, we have the conduction of pain, and we have these impulses that are going through our fibers, whether it be the A delta or the C fibers, moving to the dorsal horn and the spinal cord, all the way through to the brainstem, the thalamus, and finally the cortex. In transmission, we have the excretion of substance P, and we're moving on to perception, where we have now the conscious awareness of pain. Perception can be affected by many things. It can be affected by our emotions, what we're thinking about, what we remember about the last time we've had pain. And lastly, the last phase is modulation. Modulation is a physiologic process, and this is when we have suppressing or facilitating of the transmission of pain signals, and it moves throughout the rest of the nervous system. Now, pain threshold is a point in which a person perceives that there's pain. Pain threshold does not vary significantly among people, and it doesn't even vary significantly within that same person over time. However, pain tolerance, this is the duration of time or the intensity of pain that the individual will endure before finally they say they can't handle this pain response any longer. The tolerance will vary widely among different individuals, and sometimes it can even vary widely over time within the same individual itself. When you're asking a person what their pain level is 0 to 10, and then you ask them what pain is acceptable, you're asking them about their pain tolerance. At what point do you want us to intervene with your pain? Intense pain that occurs in one location may cause increased pain threshold in another location. An individual that's experiencing pain in multiple areas of the body, sometimes what happens is they're only talking about the pain that's occurring in the most painful sites. After that dominant pain is diminished, then they're able to identify other areas of pain. So let me give you an example. If you drop a heavy bookcase on your big toe, at the same time, you may have had a headache and you may have had a paper cut. Once you drop that big bookcase on your big toe, your body is going to report the most painful pain. It's dominant. The rest of the pain gets diminished and pushed to the side until that more dominant pain subsides. Once it subsides, you'll then remember, oh yeah, I had a headache. Oh, my paper cut kind of stings. But until then, it's that dominant pain, that is going to take over. The first question asks, the nurse recalls the reflex withdrawal of an infected body part from a painful stimuli before the pain is perceived. What is this controlled by? So the key things here is reflex withdrawal and before the pain is conceived. The answer is the myelinated A fibers, and actually it should say A delta fibers if we want to be more specific. These delta fibers are causing a fast transmission and reflex withdrawal of the affected body part from the stimulus before pain sensation is perceived. A beta fibers just to remember and review, they also are myelinated fibers. They're much larger, and they only transmit the sensation of touch and vibration, not necessarily pain. But they do play a role in pain modulation. The smaller unmyelinated C fibers, these are stimulated by mechanical, thermal, chemical nociceptors, and they are also transmitting pain, but it's the dull, aching, burning sensations, and they're poorly localized, and usually they last a little bit longer than the A delta transmissions. And 3 is actually a distractor. There's no unmyelinated C alpha fibers. So it's 4 myelinated A, insert delta there, A delta fibers. Now we're moving on to the pathway of modulation. We have segmental inhibition, which is when the A beta fibers are stimulated and they have impulses that arrive at the same time as a spinal cord as maybe an A delta and a C fiber. So pain is being modulated here in the pathway segmentally. It could decrease the pain transmission because they're all arriving at one time. Conditioned pain modulation is when we have simultaneous pain stimulation, but we also have inhibition happening at the same time. And lastly, the expectancy-related cortical activation. This happens when we have a cognitive expectation of what we will perceive that pain to be. And that will affect how we experience the pain. So if someone had a really bad IV insertion, historically, the next time they go get an IV placed, they will feel more pain because of their cognitive expectation about what happened the last time. Now, in the context of pain perception itself, we have pain inhibitors and we have pain facilitators. So they either decrease or increase the sensation of pain, respectively. Okay, so inhibitors will decrease, facilitators will increase. And these factors are influenced by transmission and progression of the pain signals within the nervous system. Let's look at the pain inhibitors for a second. First, we're going to talk about the GABA and the glycine. The GABA and the glycine, they actually inhibit at the spinal cord. But we also have endogenous opioids. And this is, endogenous means our body is creating this. We have natural pain relieving substances within our own body. And these things are endorphins, enkephalins. These opioids can bind to the opioid receptors in the brain and the spinal cord, and it will inhibit, here it is, pain inhibitor, it will inhibit the transmission of pain signals and reduce that overall perception. So endogenous opioids are really good for our body. But we also have descending pain modulation, and this is when the central nervous system releases neurotransmitters, such as serotonin, norepinephrine. These descend from the brain to the spinal cord, and they inhibit any transmission of pain past that. So we're trying to stop the transmission of pain signals. In the descending pathways, they can suppress the activity of pain sensation neurons. They are reducing pain perception overall. In the gate control theory, which we'll talk about later on in the slides, it helps to understand this a little bit, but according to the gate control theory of pain, non-painful input can close the gate to pain signals, inhibiting their transmission. So this theory talks about the pain inhibitors. When we stimulate the large sensory fibers, let's say applying cold to an area or massaging the area, we can actually activate non-painful inputs to inhibit or relieve our pain. With pain facilitators, we have peripheral sensitization, and this is in response to tissue injury or inflammation. Our peripheral nerves can become sensitized, which leads to increased sensation of pain. It's facilitating more pain. The chemicals get released at the site of the injury, things like prostaglandin, bradykinin. They can sensitize pain receptors, and then we're going to feel the pain more because it's transmitting more pain signals to the site. With central sensitization, we have prolonged or intense pain, and this can lead to changes in our CNS overall. But because of this, it results in amplification of pain signals. We also have psychological factors that we have to think about. Emotional, psychological things can influence our pain perception. What do I mean by emotional and psychological factors? Think about stress, anxiety, depression. These can all amplify how we experience pain, how our patients experience pain. With relaxation techniques, distraction, guided imagery, meditation, and prayer, we can elicit some positive emotions that can help alleviate the pain. We also have nociceptive facilitation that occurs here as well. And with this process, pain signals are amplified and facilitated within the nervous system. We have neurotransmitters or excitatory neurotransmitters such as substance P, glutamate. These can enhance the transmission of pain signals and increase the patient's perception of the overall pain. So all in all, we have to remember that it's a very complex phenomenon, and it can vary biologically, psychologically, and also within social and emotional factors as well. And so will our various techniques to manage our patient's pain. We're going to start thinking about how we classify pain now. Nociceptive pain, known also as physiologic pain or caused by physiologic reasons. We're also going to talk about neuropathic pain. Neuropathic pain is also called non-nociceptive pain. Acute pain, which is signaled usually by a harmful stimulus. And then chronic pain, where this becomes persistent over time. Really important in the next few slides to pay attention to the different types of nociceptive, non-nociceptive, and the classification based on duration, meaning acute versus chronic, and being able to differentiate the three classifications. So now we're going to just go a little bit deeper into somatic and visceral pain. First, we'll start with somatic pain. In acute somatic pain, the pain signals will originate from pain receptors that are in our skin, our joints, our muscles, and even our bones. Could also be other structures that are responsible for sensing pain. When any of these structures become damaged or injured, these nerve endings called nociceptors, they're going to detect the pain stimuli and send that electric signal through the nerve fibers to the spinal cord and eventually to the brain. And we talked about that pathway. The nociceptors in the affected area are going to release chemicals. These are called neurotransmitters. Think about substance P and glutamate. Remember, these are promoters of pain. They're going to facilitate pain. They're going to transmit pain signals along that nerve fiber, finally travel through the spinal cord, and then relayed to the brain. We go to interpret the pain, we perceive the pain, and then our body says, okay, I'm in pain, and I know what part of my body is in pain. So we are able to localize the pain experience. And this is when our patients will say, well, my pain is sharp, or, oh, my pain is dull, it's throbbing, I can't really tell where it is, it's kind of generalized. When we hear those things on a pathophysiologic level, we can know whether it's the A delta fibers or the C fibers that are being affected by the somatic type pain. Now we're going to talk about visceral pain. And this is the pain that we use to describe internal organ pain. So our tummy hurts, okay? The patient's stomach, intestines, the liver, maybe there's bladder pain. Unlike somatic pain, these organs have fewer pain receptors, but they have different types of nerve fibers called visceral afferents. So we call this visceral pain. That's where the term comes from. Once the visceral afferents are activated within the organ, this nociceptor will release neurotransmitters such as substance P, and it's going to signal the spinal cord, go up to the brain. It's going to be modulated and will be interpreted, and then we'll know where the pain is coming from. But visceral pain, the way most people describe this pain, you'll hear things like poorly localized, it's deep, it feels dull. Cramp-like sensations are a way that we can talk about visceral pain. Think about menstrual cramps. The organ is being affected. It's also more, it's not as localized as somatic pain. So we have very diffuse ability to understand exactly where on the organ, but the whole organ kind of feels like it's being affected. Visceral pain can be accompanied by autonomic responses like increased heart rate, increased blood pressure, diaphoresis. That is caused by acute visceral pain. Referred pain. Referred pain is this phenomenon where the organ or the tissue that is in pain by the noxious stimuli is actually sending signals to other parts of our body where it's communicating that that's where the pain is. Let me give you an example. I had a patient who was having an acute MI, female patient, but instead of having any pain in her precordium area, she was having lower back pain. And somehow, because women present atypically for myocardial infarction, her pain was being perceived in the lower back area. So that's referred pain. The schematics here will show you the different organs and where you might actually experience pain. For someone with a UTI or a lower bladder infection, they may actually feel pain in their sacral area, their bladder, but also maybe even in the lower buttock area as well. This pain from the bladder is being referred elsewhere. The area of referred pain is supplied by the same spinal segment, though, as the site. Okay, so it's never going to be where if it's your lung, you're going to feel it in your feet. It's going to be in that same segment of where the pain is actually derived from. You can have acute referred pain, and you can also have chronic referred pain. So let's define chronic and acute. Chronic pain is anything that lasts 3 months or more. Acute pain is less than 3 months. Chronic pain is still poorly understood, though there's research coming out every day that has to do with pain theories on chronic pain, best ways to relieve chronic pain. But usually, chronic pain doesn't respond to the typical therapies. Patients that have chronic pain actually can be referred to chronic pain clinics that are more equipped to handle the types of chronic pain, and they have more resources and specialists that deal with other ways to promote pain healing other than pharmacological ways. Chronic pain doesn't serve any protective purpose. With acute pain, we know acute pain helps because if we didn't have acute pain and we're holding that hot pan and we don't have that acute pain sensation, we're going to hold it until our skin burns off. So we need acute pain. But with chronic pain, and that's just one example, but with chronic pain, there's not really a purpose of why our body needs to be in pain for elongated times. There are some theories. It's thought to be caused by a dysregulation of our body's ability with nociception and pain modulation within the peripheral and the central nervous system with the sensitization. It also might be due to behavioral or psychological changes. Studies have shown that a person that is depressed or suffering from anxiety is more likely to experience chronic pain. Also, chronic pain is more likely to cause depression as well. So it can be rather circular there. Now we're going to define neuropathic pain. And most of the time when we think of neuropathic pain, we might think about diabetic patients and diabetic neuropathy. But this is only one type of neuropathic pain. Neuropathic pain tends to be chronic. It originates from the problem in the nervous system itself. It's not always an organ or tissue, but it's just the nervous system. And there's damage there in the nervous system, or there's a malfunction in the way the nerves are transmitting the pain signals throughout the areas of our body and getting to our brain and then back to our body. Well, let me give you an example. If someone has nerve damage, they are going to experience neuropathic pain. It's a result of the dysfunction of that nerve ending, and it can be for various reasons. An injury, maybe there was infection at the site, certain diseases, again, diabetes, multiple sclerosis patients experience neuropathic pain as well. Also, we can get neuropathic pain as side effects of some medications. Abnormal pain processing occurs with neuropathic pain. This damaged nerve is sending bad messages. Incorrect or exaggerated pain signals are going to the brain. These abnormal signals are interpreted by the brain, and the brain is saying, oh, I get it. It's really intense. You're experiencing something really bad. And even the absence of pain can be perceived as pain. Nothing's really there that's causing pain. There's no noxious stimuli, but because it's a breakdown in the nervous system, your body is still experiencing pain. Neuropathic pain, what is the patient going to describe it as? Shooting, burning, shocking, tingling sensations. It can be persistent or it can be intermittent. It can be very localized or can radiate through the nerve pathway. Patients with neuropathic pain, sometimes they'll say that if you just touch me, I have a heightened sensation of that touch. Or they're really affected by extreme hots and cold, but also not extreme hot and cold. Any variation in change of environmental temperature can also be perceived as pain for these patients. How do we treat these patients? Well, the treatment itself, we're just trying to manage the underlying cause. But if in most cases we don't know the underlying cause, it's really hard to alleviate the pain. We can use medications like antidepressants, anticonvulsants, and just over-the-counter pain relievers sometimes to try. Because it's neuropathic pain, nerve blocks sometimes can help. Physical therapy can help. And in most cases, neuropathic pain, there has to be some component of a psychological or psychosocial intervention and lifestyle modifications. Again, remembering that chronic pain serves no purpose and is poorly understood, we know that it will last 3 to 6 months or even more. We will call it persistent chronic pain when it leads to a physiologic adaptation, meaning that initially this pain is causing some manifestations that we're used to seeing with pain. But now someone in chronic pain and it's persistent, their heart rate can be normalized, their blood pressure is normalized. There's still some underlying stress, but we can't see the outward manifestation. Other times, we might see other psychological changes, such as defects in cognition, increased depression, difficulty eating, difficulty sleeping. Patients that suffer from persistent chronic pain are difficult to take care of holistically because we fail to understand that we're not going to see the same signs and symptoms as someone in acute pain. So I've heard often in healthcare where a provider will say, I don't think they're in pain. Well, how do we know? Because we're not seeing those normal, or what we consider normal, manifestations. Just because their heart rate and their blood pressure are stable, they don't look overly stressed, it's because they have adapted to this pain. With chronic pain syndromes like fibromyalgia, for instance, it's very specific and non-specific pain that they can have. Actually, in fibromyalgia, it's diagnosed when there's pain. I believe it's up to like 15 points of the body where there's 15 areas of pain. Many individuals of all ages can have recurrent pain. Some of them, spinal pain, can be very non-specific, hard to manage. Another hard to manage pain syndrome is myofascial pain syndrome, where there's injury somewhere in the muscle of their fascia or even the tendons. So they get this deep, aching, very localized pain, and sometimes it can be very generalized, deep, aching pain. Post-op pain can happen. It happens when there's changes in the PNS and the CNS, and we can have what we call allodynia and hypersensitivity, when now even the slightest touch is perceived as pain. They're just in chronic, high intensity pain. And then what I don't know a lot about because I haven't experienced it, I haven't had many patients that have been able to talk about their cancer pain. There is cancer pain syndrome, which tends to be very dull to severe and very chronic. It can be intermittent or can be persistent, but it has to do with the pain from the cancer cells, but also the theory is it's also due to the chemotherapy and radiation treatments causing this cancer pain. Sometimes central post-stroke pain can be evident with a patient after they've had a CVA. And usually it has to do with an ischemic CVA that has now changed the sensation of half of their body. And they have this hypersensitivity. So if we remember or we have read about stroke before, if our stroke is on the right side of the brain, it typically is affecting the opposite side of the body. So if our stroke patient is having a stroke on the right side, after a while, chronic pain, we might see an overall hypersensitivity to that left side of the body over time. Phantom pain can also fall under neurologic pain as well. Phantom pain is this pain that we feel or a patient will feel after a body part has been amputated. And even though they have this amputation, they're not able to see or feel, touch that limb anymore because it's gone, but they're still perceiving that pain to be there. Okay, so it still feels like their big toe is there, even though it was amputated due to gangrene. But really the toe is not there, but they're still having that pain signal to the brain. The brain is interpreting it as being in a place where there's no longer a limb. And then we have the complex regional pain syndrome, CRPS, and this is also associated with limb injury. Which finding would the nurse expect to recognize during the assessment of a person with chronic pain? We remember that with chronic pain syndrome over time, our body adapts. So they may not have any tachycardia. I want you to be careful to not think that if someone is in chronic pain that they may be faking their pain because of this adaptation. We have to be careful not to judge. Over time, people with chronic pain may not be hypersensitive anymore, again, due to this physiologic adaptation. But we might see some psychosocial changes such as depression. If we do not relieve chronic pain, we can cause impaired productivity and quality of life to this patient. They're going to experience depression, anxiety, inability to concentrate. It can reduce mobility. They can't sleep. They're not eating well. All of this can trigger a stress response that we can't outwardly see. And we know that stress impairs our immunity. So it becomes susceptible to disease. Chronic pain can lead to destruction of relationships. It may cause increased medical bills, impaired quality of life with the things that they used to love to do with their pastimes. They tend to have longer admissions and readmissions in the hospital as well. So what is our role? In MedSurg, you're going to get this in more detail, but I just want you to think about now, our role in pain is to acknowledge it, to identify where that source of pain may be, and then we have to reassess. Okay, so if we check the pain and we try an intervention, always reassess. Maybe they didn't want an intervention before, but now they might need an intervention. So that assess and reassessment, that documentation is highly important. We need to help the patient to understand what effective pain management means to them for that type of pain. And this is going to be patient-centered. It includes their family, their significant others, their support system. Make sure that you are evaluating often, documenting often the effectiveness of your pain. If you start the day with a pain level of 3, make sure you're going and reassessing each time that you're seeing the patient, again, because it changes over time. And lastly, we need to advocate. We need to advocate for appropriate patient and family effective pain management. And sometimes this doesn't happen. And I'll give you an example. A procedure needs to be done at the bedside, like a chest tube. We got to put the chest tube in immediately. We don't even have time to go to the OR. Sometimes, because of this immediate need or necessity, we forget that maybe we need to get some morphine or localize our local anesthetic to that area. And while the surgeons and the medical team are moving so fast, it's our job to advocate for the pain of our patient, the patient, advocate for their well-being and see if we can't give them something to manage the pain for the procedure. In pediatrics, I'm not going to spend too much time. You'll get more of this in 3rd semester, but remember that pain is different. We actually have nociceptors in our bodies as early as 20 to 24 weeks gestation. So when we get these micropreemies delivered, they can already experience pain. When we have our infants, our pediatric patients, we're looking more at facial expressions, their body movements. Are they tense? So we're checking their tone. How can we console them? Is it really hard to help them to stop crying? Children from 5 to 18 have a lower threshold than adults. And this helps us to remember that we need to even more so address the pain of our pediatric population. There is anatomical and functional ability to perceive pain. With our aging adults, we know that older individuals may or may not have an increased pain threshold. It varies. In all age groups, though, studies have shown that women appear to be more sensitive to the same type of pain than men. pain in older adults can be influenced, though, with our aging organs, let's say. With our liver and our renal function, as they decrease, it also alters the metabolism of the drugs that we may give our patients to help modulate or affect their pain. Their pain tolerance decreases as well over time. So even though women perceive pain more sensitively than men, everyone's tolerance starts to decrease as we get older. I'm going to go quickly through the different theories of pain, starting with the specificity theory. The specificity theory is talking about the amount of pain that's related to the tissue injury and is very direct. And there's 4 types of sensory receptors: heat, cold, touch, and pain. We have dedicated pathways and localized pain. Now, this theory talks about pain fibers and that they're very dedicated to transmitting pain signals to the brain. The specificity theory implies that pain is a direct result of the activation of a very specific receptor and a very specific fiber. Now, the specificity theory only laid down the foundation of understanding pain. But now we know that it's more of a multidimensional experience that is occurring when we have a patient going through pain. Now think psychosocial, physiological, and psychological. The pattern theory of pain, this was the expansion of the specificity theory. And this pain theory suggests that the pain perception isn't determined just by the dedicated pain receptors, but also patterns of nerve impulses that are generating in various sensory outputs. So according to the pain theory, we have cognitive and psychological contributions. Chronic pain we have to think about, and phantom limb pain we have to think about as well. This theory tells us that pain perception arises from the patterns at the neural activity generated by the sensory inputs from the nociceptors, as well as sensory receptors. This pattern or activity of transmitted information through nerve fibers, they form a pattern that represents the whole pain experience. So it's much more involved and evolved from the specificity theory. The same scientists, Melzack and Wall, who talked about the pattern theory, also talked about the gate theory. Melzack and Walls in 1965 also talked about the complexity of the pain phenomenon overall and how the mind and the brain is so important in that pain perception. This theory suggests that there are gates or mechanisms in the spinal cord that either facilitate or inhibit the transmission of pain signals to the brain. We talked a little bit about these inhibitors and facilitators already. These pain signals transmit through the specific nerve fibers, again called the nociceptors, and then they detect and transmit that pain stimuli to the brain, where the brain perceives it and interprets it. The gate controls the flow of the pain signals to the brain. We know that there's an influence of other factors. This theory considers the psychological, cognitive factors in the pain perception. And this is why this theory is more evolved than the 2 previous theories. It also talks about the interplay of both the PNS and the CNS. We do have nerve impulses that encounter the pain at these gates. Just a reminder, these were the excitatory and the inhibitory neurotransmitters. Excitatory, the gates open. Inhibitory, the gates close. This was a first order neuron step. Because there's been much research on the gate control theory, this really has paved the way for further information and study on the cognitive and the behavioral approaches to achieving maximum pain relief. We know now that pain messages can be overridden by other signals like heat or cold, acupuncture, acupressure, PT, massage. These all can help pain. Transcutaneous nerve stimulation can help pain. You can actually get a TENS machine, which is what transmits this transcutaneous nerve stimulation, on Amazon. And you've probably seen it. There are wires connected to a box with buttons and controls on it and stickers, or kind of like cardiac EKG stickers. And you can put them on areas of the body to transmit small signals to help modulate pain. We know prayer, guided imagery, music, relaxation, distraction, and also biofeedback are appropriate ways to modulate pain, all coming from this gate control theory. And then lastly, Melzik decided to do more research, and around the 1990s, I think all the way up until 1999, he has updated this more comprehensive model of pain, and we call this the NEUROMATRIX theory. It's taking the gate theory and talking about now this paradigm shift. It tells us that pain is not solely determined by the sensory output, but also influenced by multiple factors: sensory, cognitive, and emotional processes. It is including the brain, the spinal cord, which is where we get the production of pain and not tissue damage. We have multiple parts. The brain, the spinal cord, they work together in response to whatever that noxious stimuli was. Then the environment also contributes on how we experience the pain. So it's not just how the brain and spinal cord are working together, but what else is going on, making it more of a holistic approach to understanding pain.